Yeah, well, last time I had a cardiac you were talking about vaccination in that child and what we're going to do about it. There are probably still no answers for that. Anyway, our next speaker is Professor Sunnyfield. He's a consultant pediatric neurologist at Mediclinic City Hospital, Mediclinic Parkview, and Mediclinic Welcare, basically the entire Mediclinic group in Dubai. He's an adjunct clinical professor at MBRU, which is based in Dubai, and he's going to talk to us about hereditary neuropathies in children and adolescents, and taking us through the guidelines and recent advances. Dr. Sunny.
Thank you, Arif. Good morning, everyone. It's a pleasure to be here this morning in my select group in a very popular conference. And thank you for the organizing committee of this conference. This morning, we've been talking about rare conditions as has been the theme of the conference. Hereditary neuropathies are in itself rare, but common cause of neuropathies presenting in children and adolescents. Okay, then a condition which is as diverse and as rare as neuropathies, particularly acquired hereditary neuropathies, there's a confusion of how do you assess a child, how do you investigate, because assessment and investigation often will lead to appropriate management, prognostic discussion, etc. So there was a committee where we found that these are practices, these are rare conditions, so to be able to gather enough patients to form a proper randomized control trial into any specific disease is very, very hard. So the guidelines have to be drafted by consensus of people like us, experts who are sitting here, people who see these patients, to devise a path through this confusion, which is the most appropriate way of dealing with it. So these guidelines were drafted with a wide variety of pediatricians and specialists, neuropediatricians, neurologists, clinical neurologists, genetic counselors, and counseling services, pediatric neuroradiologists, neuropathologists, metabolic specialists. And this was with the intention of providing the orientation regarding the diseases of the peripheral nervous system in young children and adolescents. And these guidelines were published fairly recently in 2021. And the aim is to describe the state-of-the-art differential diagnosis and the consensus-based, targeted, and cost-oriented diagnostics. So really to find out what's the best way of investigating and which investigations should be targeted for which patients, etc. Just to give you a slight introduction of, tell you about peripheral neuropathies. Peripheral neuropathies are among the most frequent diseases we see in children. Among themselves, there is a spectrum of etiology and clinical presentation, and the disease course is quite broad. So children come to you with neuropathies, like diabetic neuropathies, when they do happen, they happen much earlier in children than in adults. While if you look at children, metabolic and hereditary etiology is much more prominent. The difficulty in pediatrics also is neurophysiological investigations like nerve conduction study and EMG are much more distressing for children than for adults. And very few pediatric neurologists are fully trained now as neurophysiologists to do these detailed and sometimes very, very complicated studies in nerve conduction and EMG. I'm just going to give you a splattering of cases to give you a taste of the variation of peripheral neuropathies we come across in children and adolescents. This is a common presentation we see as an acute neuropathy, 12-year-old tripping while walking, and over a week, condition is worsening. By day 8 of presentation, he had difficulty in walking. He, on questioning, had some sort of respiratory infection a couple of weeks ago, and his weakness was very peculiar because it was mainly peripheral. So his leg muscles were weak, anterior tibialis, gastrocnemius, bilaterally he had a foot drop, while his hip girdle muscles were normal, as well as the upper extremities. And this was progressive. His reflexes were absent. He was investigated, and he had a lumbar puncture done as per the investigation, which showed high protein, normal cells in the CSF, no cytological dissociation, and his MRI scan of the brain was normal, but the spine showed enhancing caudal equina roots, so enhancement of the peripheral roots, confirming the diagnosis. Another case, different peripheral neuropathy. This is a chronic peripheral neuropathy, slightly slow onset. A 6-year-old boy presented with a 3-month history of progressive weakness. He lost his ability to walk independently. He had near normal strength in the bilateral proximal muscles, but he had weakness in the peripheral muscles. Again, weakness was much more in the foot muscles than the upper limb. His sensations were preserved, but he had no reflexes. And on investigation again, you could see that this was an infant polyneuropathy. Chronic variety with a CSF analysis showed high proteins with no white blood cells. What about this condition, where you see a 7-year-old who's been tripping and falling, and he has sort of a foot drop gait because he's tripping and he cannot pick his feet. On detailed history taking, we find on the mother side of the family there are family members who needed special shoes for the high arches, and their feet have started to turn in, their toes have started to claw. This particular child had negative Gowers, that means his peripheral hip girdle muscles were strong. This is not looking at myopathy. In his hands, he had some weakness, and his legs also there was weakness. He also had absent tendon reflexes, but no fasciculations, so no anterior palm cell disease. His calf muscles were atrophied, and he had high arches in the lower extremities. He had high step and foot drop gait, and he had vesicles. So this is a chronic inherited neuropathy. The history, the examination, the length of time tells you that. It's commonly known as type 1 or Charcot-Marie-Tooth disease. What about this one? It presents again as a slightly chronic condition. The etiology is very different. A 16-year-old left-handed girl with a 6-month history of numbness of the left hand. She feels her handwriting is mildly affected. There's no associated pain. And when you take the history, you get the history that when she drives, when she drives or driven from school, she tends to keep her left hand on one side while she is using a phone texting her friends. Therefore, she's putting pressure on her other limb. She had mild atrophy of the muscles of the trochlear, and she had decreased sensation in the 4th and 5th digits. Only the left ulnar reflex was diminished. So this is a very specific damage to the ulnar cubital fossa syndrome, which is due to pressure. But if you investigate this, there are conditions like hereditary neuropathy or pressure palsy, groups: hereditary and acquired neuropathies, very clearly. And the hereditary neuropathies are multiple types. The hereditary motor sensory neuropathies, and among the whole group of hereditary, if you look at it, the CMT type 1, or the motor sensory neuropathies, occupy about 40% of all the hereditary neuropathies. So there's one single genetic condition which takes limelight. Therefore, when you're investigating it, it's important to focus on that condition rather than focus on the minorities. When you eliminate that, then you go ahead and look and investigate the other ones. Of course, in the motor sensory neuropathy, there are multiple types: CMT1, CMT2, CMT4, CMT X-linked. Then there are other conditions like hereditary motor sensory, hereditary sensory and autonomic neuropathies, which is also type 1 and 2. The hereditary motor neuropathies, episodic neuropathy. I talked about hereditary neuropathy with pressure palsy, which is the one you get neuropathy due to pressure. And then there is hereditary neuralgic amyotrophy, where you get pain in the shoulder and the arm episodically, and that leads to weakness of the muscles and wasting of the muscles. Then there are syndromic neuropathies along with other neurometabolic conditions or neurodegenerative conditions like metachromatoleukodystrophy, mitochondrial disorders, etc. So there's a whole bunch of conditions we see as hereditary neuropathies. Not to say that acute neuropathies are, acquired neuropathies are also very important. And as I showed you, the Guillain-Barré, the CIDP, they are inflammatory polyneuropathies. They could be infectious, post-infectious, vasculitic. There's a whole group of toxic, metabolic, vitamin deficiency, paraneoplastic, critical illness neuropathies, and small fiber neuropathies in the polyneuropathies. Then there's a smaller group of mononeuritis multiplex. We don't see that as commonly in children, it's more common in adults. And then single nerve neuropathies could be traumatic, could be inflammatory, could be tumors, or nerve compression syndrome. They are also seen in various things. Neurofibromatosis may lead to certain tumors growing in the nerves and therefore lead to mononeuropathies in particular nerves. And then neurologic shoulder amyotrophy could be acquired as well. So when you talk about peripheral nervous system disease, how does a child come to you with a peripheral nervous system? How do you recognize this child's got peripheral nervous system disease? Of course, the symptoms are the first thing to focus upon. If the symptoms are a single focal lesion, you get weakness, numbness, pain in one limb, often defined to part of that limb rather than the whole limb. And if you've got multiple or diffuse lesions, you get the weakness, numbness, and pain in more than one limb, usually bilateral, usually distal, not peripheral. And the signs are equally easy to pick up. If you focus on them, you get atrophy, fasciculations, hyperreflexia, areflexia, and then patchy sensory loss or glove stocking anesthesia. It's very different from the upper motor neuroscience where you get increased reflexes, spasticity, increased tone, decreased change in consciousness, etc. The common cardinal investigations, if you think about it, if you have a child who presents to you with peripheral neuropathy, where do you start? You of course do serology, there are blood tests. Essentially you're trying to focus on treatable causes. There are lots of treatable causes, I'll come to that in a minute. But your serologies are focused on acute or chronically treatable causes. Then you look at nerve conduction lineage. They're key to diagnosing different types of peripheral neuropathies and for localizing the lesion. Imaging, if you appear to have some focal lesions, then imaging is really important. Or you have to do imaging to exclude CNS mimics, demyelinating lesion, cord lesions, stroke. They might mimic peripheral neuropathies, and therefore you have to do that. And particularly in acute Guillain-Barré syndrome, to pick up the cord-iguana roots enhancement, MRI spinal cord. CSF analysis was very important in acute inflammatory or demyelinating neuropathies or easier to do, and much more. The hereditary neuropathies can be axonal, can be demyelinating, can be autonomic, and can be distal. There's a whole splattering of genetic conditions which are causing hereditary neuropathies, which can be diagnosed. So when you suspect a hereditary neuropathy, the first thing, as I said, 40% is CMT1. So you focus on CMT1. Gene deletion, with a duplication or deletion, and if that's negative, you look for HNPP, and then you can look for panels for neuropathy. Now, this is a nice flow chart of how you logically follow that depending on expense. But now, as genetic investigations are becoming cheaper and cheaper, it may be shifting towards doing whole exome sequencing, which includes pretty much all the panels at the cost of what the single gene test for before. So the economics of this is changing, and therefore the practice is changing from what has been previously established. There's a whole test aimed at very treatable pathologies like GBS, you've got Refson's disease, you've got AB dyslipidemia, vitamin E deficiency, multiple vitamin deficiencies, CDD syndrome, metachromatic leukodystrophies, and so basically you try to investigate them to try and find out these treatable pathologies. Because treatments are available in various forms, in either vitamin therapy or bone marrow transplant or even gene therapy. So what does the consensus tell us? Very quickly going through that thorough history, that is key to the important progress towards assessment, including family history. Detailed neurological examination and clinical examination. Cornerstone investigations are electrophysiology, nerve conduction studies, EMG, imaging, CSF diagnostics, lab workup, toxicology, and molecular genetics. And they are focused by looking at the patient's medical history and clinical findings. If you suspect a mix of peripheral and central nervous system disease, do visual erode potentials and auditory erode potentials. And if you suspect small fiber neuropathy, then sensory testing is really very important. For autonomic neuropathy, it's important to look at autonomic functions like heart rate variability, tilt table testing, and again, focusing the MRI for local or regional neuropathies, where you don't find an etiological outcome. So if you have neuropathy and you can't find an etiological diagnosis, then MRI becomes important. Molecular genetics is shining as a new boy on the scene in terms of easy access, low cost now to do whole genetic screening as a single shot. You can do neurophysiological investigations like nerve conduction studies and EMGs repeatedly to try and keep a track of progress in terms of improvement, follow-up, prognosis, thereby helping us enable to look at the natural history but also prognosticate better and see what treatment interventions we do are effective or not. If you suspect an infective pathology like Lyme's disease, look for the serology. If it is a demyelinating, fluctuating cause, then it is important to look at things like CSF protein and MRI span, and then therapeutic interventions are become important, IVIG, plasmapheresis, steroids. And for patients who are resistant to that therapy, look for additional rare things like paranormal proteins, and also look for hereditary etiology, because some of it may be looking like inflammatory, may have an underlying hereditary neuropathy. In children, toxicology is important. Overall, if you look at it now, if you suspect hereditary neuropathies, molecular genetics is important. And though we can do segmental investigation like single gene, panel genes, whole exome sequencing is probably the way to go nowadays. So, in summary, diseases of peripheral nervous system are highly diverse in etiology, and they affect children and adults differently from what we see in adults. And the spectrum is very different in children and The approach is based on solid clinical examination, history taking, and assessment followed by a core of investigations which include blood workup, EMG nerve conduction studies, MRI scans, genetic investigations now, and nerve conduction in EMG. Genetics, as I said, is now focusing more on whole exome sequencing. So overall, if you think of it, it's a very complex condition, but with the right thought process, with a good clinical examination, assessment, investigation, you can arrive at a diagnosis that will help us treat many of these very treatable conditions. Thank you.
Time for 2 questions. Anyone? I have one for you, sir. I see a lot of patients coming to us who have inherited neuropathies on a cocktail of vitamin B supplementation. Of course, there are no treatments or cures available for these chronic conditions, but what's your practice? What do you do with these kids who are on this concoction of vitamin B supplementation?
Well, I think there are, of course, wide neuropathies which are very clear. They are multiple vitamins. It's quite rare. Investigate them is quite difficult. But if there is a specific vitamin deficiency, of course, that is important to supplement it and chronic supplementation. I think a cocktail without any specific reason doesn't really augment health, because most of these micronutrients are pretty good in our body if you're eating a normal healthy. If you've got a fatty diet, like many kids of autistic have fatty diet, they will end up having problems with multiple vitamin deficiencies, which could lead to neuropathies, which are very difficult. Of course, modern genetic treatments are coming. As we all know, there's no specific genetic treatments in peripheral neuropathies. Particularly, if you look at it, major condition, what we've got, CMT1, is a gain of function mutation. So unlike gene replacement, where you're replacing an effective gene, what you've got to do is silence them to be effective. So because of this multiple variation, there are multiple modalities being explored now. Gene silencing, CRISPR technology to modify genes, some gene replacement in X-linked neuropathies. These are all in the horizon being studied. Lots of animal studies are ongoing. No definite clinical treatment available yet.
We talked about this on the day 1 on MECP2 Tourette syndrome as well, where you have this antisense oligonucleotide, where you suppress MECP2 duplication syndrome. Genetics is the way forward.